So the next topic which we will discuss is neuromuscular blocker. So our next topic is neuromuscular blocker. Now guys, all the drugs which I will discuss in this topic, they act on neuromuscular junction, right? I would divide this neuromuscular blocker in two groups, depolarizing and non-depolarizing. But all the drugs which I would discuss, they act on neuromuscular junction. So things would become very easy if we revise a normal action at neuromuscular junction, right? Because if we know normal, it is very easy to understand their mode of action and all other properties. Okay? So let us very fast have a recap of a normal activity at a neuromuscular junction. Okay? See, this is your nerve and this is a muscle. And this is neuromuscular junction. Okay? This is nerve, this is muscle, this is neuromuscular junction. Whenever the nerve is stimulated by any stimulus, electrical, a magnetic, any kind of stimulus, when the nerve is stimulated, what happens? The nerve is stimulated. Acetylcholine stored in acetylcholine vesicle at nerve endings, they break. And acetylcholine is released in neuromuscular cleft. On muscle end plate, there is a receptor. This receptor is called nicotinic cholinergic receptor. Okay? Now this receptor has two subunits. Actually, it has 5 subunits. 2 alpha, epsilon, gamma, delta. But our concern is the alpha subunits. So it has 2 alpha subunit. Acetylcholine attaches to both the alpha subunit, cause electrical depolarization in the receptor, and as a result of electrical depolarization, we have a mechanical muscle contraction. Correct? So we have a muscle contraction. Acetylcholine deattaches from the receptor very fast, and there's an enzyme called acetylcholine esterase. This comes into action, destroys acetylcholine. Again the receptor is ready to accept a new molecule. Again a depolarization, again a contraction. The cycle go on, and we get a coordinated muscle movement. So for a coordinated muscle movement, we need a depolarization of nicotinic receptor and an equally fast repolarization of nicotinic cholinergic receptor. Any problem in depolarization or repolarization would result in a muscle paralysis. Got it? Now neuromuscular blocker is divided into two groups. Depolarizing and non-depolarizing. So we would discuss them in two groups, depolarizing and non-depolarizing. Okay? The only example belonging to the first group, depolarizing, the only example is succinylcholine. Okay? This is the only example belonging to this group, succinylcholine. Okay? So whatever I would discuss about depolarizing neuromuscular blocker, we are discussing about succinylcholine. Rest all neuromuscular blocker are non-depolarizing. Okay? Now let us discuss their mode of action. My opening statement for succinylcholine is, it's mirror image of acetylcholine. Okay? It is 2 acetylcholine molecule attached to each other. So let us say, I gave my patient IV succinylcholine. Okay? It goes to the neuromuscular junction, the target organ, attaches to the alpha subunit of nicotinic receptor, causes a depolarization. This results in a contraction. Till now, everything is similar to acetylcholine action. But unlike acetylcholine, it doesn't detach as fast. Keeps sitting on the receptor and keep the receptor in depolarized state. Receptor does not get repolarized and the muscle paralysis result. So what is the mode of action of succinylcholine? Persistent or prolonged depolarization of nicotinic cholinergic receptor. ठीक है? Persistent or prolonged depolarization of nicotinic cholinergic receptor. Got my point? Okay. Let us talk about how does non-depolarizing act. I gave my patient IV non-depolarizing. To understand mode of action of non-depolarizing, we must be familiar with a word which we must have read in pharmacology, competitive antagonist. Competitive antagonism. What does competitive antagonism means? Two molecule, original and a duplicate, competes for same site. If original wins, a normal action takes place. If duplicate wins, no action takes place. So non-depolarizing neuromuscular blocker is the duplicate for acetylcholine. When I give it, it goes to the neuromuscular junction, and non-depolarizing and acetylcholine compete with each other for the alpha subunit. Okay. If acetylcholine wins the competition, it goes and sit on the receptor, does a normal action. But if non-depolarizing wins the competition, it goes and sit on the receptor and do no action. Now, who wins the competition? How it is decided? According to the quantity at neuromuscular junction. Whichever molecule is in more quantity, it will win the competition. If acetylcholine is more in quantity, it will win. If non-depolarizing is more in quantity, it will win. Got it? This is called competitive antagonism. Here, receptor is normal. The only problem is quantity of non-depolarizing neuromuscular blocker. There is no problem in the receptor. If by some means I increase the quantity of acetylcholine again, I can reverse the muscle paralysis produced by non-depolarizing. Same I can't achieve with succinylcholine. Reversal I can't achieve with succinylcholine simply by increasing the quantity of acetylcholine. Why? Because there the receptor is in depolarized state. Got it? So let us write mode of action. Succinylcholine, what is the mode of action? Number one difference. Mode of action is persistent or prolonged depolarization of nicotinic cholinergic receptor. Right? Persistent or prolonged depolarization of nicotinic cholinergic receptor. What about non-depolarizing? Competitive antagonism. Competitive antagonism. Non-depolarizing mode of action, competitive antagonism. Okay. Now, second point. How does acetylcholine act? Attach, depolarize, contraction, no repolarization, paralysis. Right? Before this paralysis, there is a contraction. This is not a coordinated contraction. This is a twitch, a flicker of contraction seen in every muscle of the body. This has been given a special name. It's called fasciculation. So succinylcholine, prior to paralysis, there is a fasciculation seen. Once the fasciculation passes, then there would be a paralysis. So second point, fasciculation is seen. Fasciculation is seen. Non-depolarizing, no fasciculation. No fasciculation. Because they sit on the receptor passively. Now, third point. Why? Because of this fasciculation seen with succinylcholine, let's say 30-40% patients post-op, after completion of surgery, they are reversed and shifted to post-op room, and when they start walking, ambulating, they complain of generalized muscle pain. This is called post-operative myalgia or post-operative muscle pain. This post-operative myalgia or post-operative muscle pain is because of fasciculation. So it will only be seen with succinylcholine, which only produces fasciculation. It won't be seen with non-depolarizing. Got it? So post-operative myalgia seen. It's not post-operative muscle weakness. It's post-operative muscle pain normally present after succinylcholine. Post-operative myalgia. Here, no post-operative myalgia. No post-operative myalgia. Right? Okay. Fourth point. Now guys, I told you, if I simply increase the quantity of acetylcholine, I can reverse the muscle paralysis produced by non-depolarizing, not by succinylcholine. See this acetylcholine esterase, which we talked about. This metabolizes what? This metabolizes acetylcholine, right? This metabolizes acetylcholine. This is a very active enzyme. If I stop the action of this enzyme temporarily, I can I can recruit the quantity of acetylcholine by stopping its metabolism. Acetylcholine will increase in quantity and the reversal from non-depolarizing is possible. An example of anti-acetylcholinesterase, neostigmine. So reversal by neostigmine is only seen with non-depolarizing. So fourth point, succinylcholine not reversed by neostigmine. Not reversed by neostigmine. Right? Non-depolarizing reversed by neostigmine. Right? So I think these four differences clear. Succinylcholine is not reversed by neostigmine and non-depolarizing is reversed by neostigmine. Right? Non-depolarizing are competitive antagonists. Simply by increasing the quantity of acetylcholine, I can reverse the muscle paralysis produced by non-depolarizing. Got my point? Okay. So 4 points clear. Fifth, sixth and seventh difference are the differences based on something called train of force stimulus. So let us understand first what is train of force stimulus and then we will write fifth, sixth and seventh difference. Okay. Now see this. This is, let's say, this is the nerve, this is the muscle. If I give single stimulus to the nerve, we call it single muscle twitch. But if I give 4 stimulus of equal strength, if I give 4 muscle twitch of equal strength, I give 1 hertz, 1 hertz, 1 hertz, 1 hertz. 4 stimulus of equal strength. We call it train of force stimulus. This is called train of 4 stimulus. It's called train of force stimulus. And whenever we give train of force stimulus, in muscle, 4 contraction is noted. We see 4 contraction in the muscle. Got it? Let us say I gave my patient depolarizing neuromuscular blocker. Right? Whenever we give depolarizing neuromuscular blocker, what happens? Succinylcholine. It immediately comes to the neuromuscular junction and it depolarizes most of the nicotinicholinergic receptor. Few receptor may be empty. Most of the receptor in a persistent depolarization state, few receptor may be empty. Now after giving succinylcholine, when I give this train of force stimulus, whatever acetylcholine will be released by them, they can only act on the receptors which are normal, not on the depolarized receptor. So normal receptors are very few in number now because of the effect of succinylcholine. So I get 4 contraction of very mild amplitude. Now guys, I gave my patient, let's say, non-depolarizing neuromuscular blocker. How does non-depolarizing neuromuscular blocker act? They are competitive antagonist and their action depends upon their quantity at neuromuscular junction. And they, unlike succinylcholine, doesn't reach neuromuscular junction immediately. They take some time. So this is nerve, this is muscle. And I have given IV non-depolarizing and it is gradually accumulating. When I gave the first stimulus of train of 4, there were 500 molecules of non-depolarizing, right? So few receptors were occupied by non-depolarizing. Maximum receptors were empty. Got it? Maximum receptors were empty. So I get contraction of this much amplitude. When I gave second stimulus of train of 4, more time passed and let's say 800 more molecules of non-depolarizing accumulated. So few more receptor got occupied by non-depolarizing. So less normal receptors now. So I get this much amplitude contraction. Right? Then the third stimulus of train of 4. Again let's say 1000 more non-depolarizing got accumulated. Right? So more got occupied by this nicotinic receptors. Then I get this much amplitude contraction. Now fourth stimulus, all let's say 2000 more non-depolarizing reached. All the receptor is filled with non-depolarizing. Now a very small contraction or let's say no contraction seen. So 4 equal strength stimulus is producing a lesser and lesser response. With first I got a better response, then less, then less, then less. Why this is happening? Because more and more non-depolarizing is reaching the neuromuscular junction and occupying the nicotinicholinergic receptor. Right? This is called fade and fade on train of 4 stimulus. And this is what is called train of 4 response. This is what we call train of 4 response. This fade, we call it train of 4 response. So definitely fade is only seen in non-depolarizing. So train of thought response is only seen in non-depolarizing, not in succinylcholine. Got my point? Okay. Now this is A, this is B. This is A, this is B, A, B. The response produced by fourth stimulus, B. The response produced by first stimulus, A. This is called train of thought ratio. What is train of thought ratio in a normal muscle? 1. What is train of thought ratio in succinylcholine? 1. And what is train of thought ratio in non-depolarizing? Less than 1. Got it? So guys, non-depolarizing has train of thought ratio less than 1 and depolarizing has train of thought ratio 1. This train of thought ratio is the principle on which most of the neuromuscular, let's say, monitors are based. We have monitors to monitor the neuromuscular blockers, and most of the neuromuscular monitors are based on train of thought ratio. So if a patient is under the effect of succinylcholine, train of thought ratio would be 1, and if it will come out of the effect of succinylcholine, train of thought ratio would remain 1. So train of thought monitor or neuromuscular monitor is not very useful for succinylcholine. Got it? Okay. Guys, if a patient is well under effect of non-depolarizing, train of thought ratio is very less than 1. And when it approaches 1, reaches 1, patient is coming out of the effect of non-depolarizing. You getting my point? Guys, neuromuscular monitoring can only be used for non-depolarizing. We give non-depolarizing, we get a fade. I know the quantity of non-depolarizing has accumulated. And after every half an hour, we repeat the fourth stimulus. Again, a ratio is calculated. Right? If it approaches 1, the patient is coming out of the non-depolarizing. You have to repeat a dose of non-depolarizing to continue to maintain its quantity at neuromuscular junction. This is how we do neuromuscular monitoring. So it can only be done for non-depolarizing. Got it? So let us write 5th, 6th and 7th difference. Depolarizing and non-depolarizing. Depolarizing and non-depolarizing. Okay. 5th. Train of thought response not seen. Train of thought response not seen. Non-depolarizing. Train of thought response seen. Train of thought response seen. 6th. Train of thought ratio, that is B by A, is equal to 1. And in non-depolarizing, train of thought ratio, that's B by A less than 1. 7th. Neuromuscular monitoring not done for succinylcholine. Neuromuscular monitoring done for non-depolarizing. So the 3 points which we just now discussed, I have jotted down here. Right, everyone? That train of thought response is not seen in succinylcholine, seen in non-depolarizing. Train of thought ratio is always 1 in succinylcholine, less than 1 in non-depolarizing. And neuromuscular monitors are only used for non-depolarizing. So guys, what was train of thought stimulus? 4 stimulus of equal strength given at equal interval of time. Now instead of train of thought stimulus, I give a single stimulus. But single continuous stimulus I give. Tetanic stimulus of 50 Hz. Instead of 1 Hz, 1 Hz, 1 Hz, 1 Hz, 4 stimulus, I give 50 Hz or 100 Hz or a 150 Hz continuous stimulus. We call it tetanic stimulus. So whenever we give a tetanic stimulus, what happens? Whenever I give a tetanic stimulus to the nerve, there is a sustained contraction seen in the muscle. Okay? Let us say I gave my patient depolarizing neuromuscular blocker and then gave the tetanic stimulus. I get lesser amplitude sustained contraction. Let us say I give non-depolarizing to my patient and then a tetanic stimulus. Then I get a fade on tetanic stimulus. Whatever is the response of TOF, similar is the response of tetanic stimulus. No difference. Got it? Now, after giving tetanic stimulus, I wait for a minute and give a post-tetanic stimulus. Right? In case of succinylcholine, it produces same amplitude contraction. In case of non-depolarizing, it produces exaggerated response. This is called post-tetanic facilitation. Now, isn't it very contradictory? I am getting a fade and suddenly I am getting an exaggerated response. How I am getting this exaggerated response? See guys, this is nerve, this is muscle. Whenever we give a tetanic stimulus, the nerve thinks that it has to do a lot of work. Work has increased. So what does it do? Starts producing huge amount of acetylcholine in its cytoplasm. And the acetylcholine vesicle gets overpacked with acetylcholine molecule. A lot of acetylcholine molecule. Normally one vesicle has 10 or 20 molecules of acetylcholine. But after tetanic stimulus, the same vesicle will have 1000 molecules of acetylcholine. So the post-tetanic stimulus which we are giving, causing an exaggerated release of acetylcholine at neuromuscular junction in huge number. So in case of non-depolarizing, acetylcholine increasing in quantity, I get an exaggerated response. Got it? This is post-tetanic facilitation. So last difference, depolarizing, non-depolarizing. Depolarizing, no post-tetanic facilitation. No post-tetanic facilitation. Non-depolarizing, post-tetanic facilitation seen. Post-tetanic facilitation seen. Got it everyone? So these are the difference. This was our 8th difference. These are the difference between succinylcholine and non-depolarizing. Depolarizing and non-depolarizing. Right? Okay. Guys, before going into our drugs, right, I just want to give you at one place that different stimulus response in succinylcholine and non-depolarizing. We have already discussed it. So just giving it at one place, a pictorial view, so that if a question is asked separately, you can solve it very easily. So, type of stimulus, right? Depolarizing, non-depolarizing. If I give train of 4 stimulus, then in depolarizing, lesser amplitude contraction. In non-depolarizing, I get a fade. If I give tetanic stimulus, in depolarizing, lesser amplitude, sustained contraction. In non-depolarizing, I get a fade. Right? If I give post-tetanic stimulus, after tetanic stimulus, I give a post-tetanic stimulus. In depolarizing, same amplitude contraction. In non-depolarizing, after the fade, exaggerated response. So this is the scene with different stimulus in depolarizing and non-depolarizing. Remember, for neuromuscular monitoring, the most common stimulation done is train of 4 stimulus, and most common nerve which is monitored in neuromuscular monitoring is ulnar nerve. Ulnar nerve, right? We attach electrodes on ulnar nerve and see the stimulated and see the response in adductor pollicis muscle, right? So this is the most common nerve which we monitor for neuromuscular monitoring, right? Okay, so now please let us revise all the points of depolarizing that we have discussed. Depolarizing neuromuscular blocker, the only drug present, succinylcholine. Mode of action, persistent depolarization. Fasciculation precedes paralysis. Post-op myalgia, may be seen. Not reversed by neostigmin. No TOF response. TOF ratio always 1. No neuromuscular monitoring done and no post-tetanic facilitation seen. 9 points clear? Succinylcholine, 9 points clear. I would come straight away now on 10th point of succinylcholine. The first drug which I am discussing with you is succinylcholine. The first drug which I am discussing is succinylcholine, which we also call succinylcholine or we call scoline. Succinylcholine, succinylcholine or scoline. ठीक है? 9 points of this drug we have already discussed. Straight away coming on 10th point. 10th point of succinylcholine. It is fastest and shortest neuromuscular blocker. It is fastest and shortest neuromuscular blocker. Shortest neuromuscular blocker. So what do I mean by this? Fastest and shortest neuromuscular blocker. Well, I mean by this is fastest onset of non-depolarized succinylcholine is, that is when I give it, the paralysis produced by succinylcholine is within 30 to 45 seconds. So fastest onset and shortest duration. The duration for 5 to 6 minutes maximum. It produces paralysis for 5 to 6 minutes. So fastest onset, shortest duration, succinylcholine. Okay. 11th point. This drug, succinylcholine, is different from other drug in many ways. Now, the paralyzing dose of succinylcholine, guys, mind you, I'm not saying induction dose. Induction is done by inhalational and IV anesthetic agent, which we have already discussed. We paralyze by neuromuscular blocker. So paralyzing dose of succinylcholine is 1.5 to 2 milligram per kg body weight. I gave it to the patient 1.5 to 2 milligram per kg body weight. Okay? And where it has to come? It has to reach all over the body's neuromuscular junction. It has to reach all over the body neuromuscular junction, right? It has to paralyze all the neuromuscular junction, produce a paralysis in the body, right? But it has to pass from plasma. In plasma, there is an enzyme called pseudocholine esterase. Pseudocholine esterase. Right? What is the pseudocholine esterase? Guys, acetylcholine esterase is present where? Neuromuscular junction. Right? Acetylcholine esterase is present at neuromuscular junction. Right, everyone? This metabolizes only one substrate, acetylcholine, and it's called true cholinesterase. A similar enzyme like acetylcholine esterase manufactured by liver called butyryl cholinesterase, which is manufactured by liver, released in plasma, it's called plasma cholinesterase or pseudocholinesterase. Right? This is present in plasma and this comes in contact with succinylcholine. And guys, when it comes in contact with succinylcholine, 85 to 95% of succinylcholine destroyed, metabolized immediately. Only 5 to 15% of succinylcholine reach neuromuscular junction. And we get a paralysis for 4 to 5 minutes. You're getting my point? So, massive destruction of succinylcholine is happening. Little survives and we get a paralysis for 4 to 5 minutes. Okay? This is how succinylcholine normally acts. Let's say I gave my patient succinylcholine. Okay? I gave my patient 1.5 milligram per kg body weight of succinylcholine. As expected, paralysis came in 30 to 45 seconds. But as expected, paralysis didn't go in 5 minutes. 10 minutes, still paralysis. 20 minutes, still paralysis. 1 hour, still paralysis. 6 hours, still paralysis. 10 hours, still paralysis. What could be the problem? The problem could be this enzyme. This enzyme, which is manufactured by liver, may be absent. This is not there. Or if it is there, it is faulty. Whatever is the case, I get a prolonged apnea because more than 5 to 15% reaches the neuromuscular junction. Depending what the amount survives, 20%, 30%, 40%, 80%, we get a paralysis for that long period of time. ठीक है ना? This condition has been given a special name. This condition is called, succinylcholine apnea. Succinylcholine apnea. This is called succinylcholine apnea. What is succinylcholine apnea? Single normal dose of succinylcholine producing prolonged apnea is succinylcholine apnea, right? What is succinylcholine apnea? Single normal dose of succinylcholine producing prolonged apnea, right? Single normal dose of succinylcholine producing prolonged apnea. This is called succinylcholine apnea. Okay, this is called succinylcholine apnea. Got it? This succinylcholine apnea could be due to two reasons. Number one, it could be due to deficiency of pseudocholinesterase. Deficiency of pseudocholinesterase, or it could be due to presence of atypical pseudocholinesterase. Atypical pseudocholinesterase. Okay? Either the pseudocholinesterase molecule is not there, or if it is there, it is faulty. Whatever is the case, succinylcholine escapes metabolism and more reaches the neuromuscular junction. I get a prolonged apnea. This is called succinylcholine apnea. Now, how would I manage it? What would be the management of this solution? More drug has reached neuromuscular junction and patient's neuromuscular junction is under prolonged effect of succinylcholine. Patient cannot breathe. Patient will go into hypoxic arrest. We ventilate from outside. We ventilate and wait for the neuromuscular junction to recover. Right, everyone? We ventilate and wait for the neuromuscular junction to recover. Right? So, management of this situation is mainly ventilation. See guys, if I try to give normal pseudocholinesterase from outside by giving a fresh frozen plasma, or try to take away succinylcholine from plasma by doing a plasmapheresis, not much success I will achieve. Why? Because the drug is now no longer in plasma. It has reached neuromuscular junction. And as long as patient cannot breathe, we ventilate from outside. So management is ventilation. Got it? Okay. So this is our succinylcholine apnea. Now coming on the 13th point of succinylcholine. Before I tell you 13th point, let me revise all the normal properties of succinylcholine. It's the depolarizing neuromuscular blocker. Mode of action, persistent depolarization. Fasciculation seen. Post-op myalgia may be seen. Not reversed by neostigmine. Note of response. Train-4 ratio always 1. Neuromuscular monitoring not viable, not done, and post-tetanic facilitation not seen. Action come within 45 seconds, go within 5 minutes. All these properties, when succinylcholine exhibits these normal properties, then succinylcholine is in phase 1 block. Succinylcholine show two-phase block, phase 1, phase 2. Whatever is normal is phase 1 block. Got my point? Succinylcholine show two-phase block, phase 1 and phase 2. Whatever is normal is phase 1 block. Right? Whatever is normal is phase 1 block. That is, when succinylcholine is behaving like a depolarizing neuromuscular blocker, which it is. It is in phase 1 block. That is, when it is showing train-4 response, negative, train-4 ratio, 1, and post-tetanic facilitation response, negative, it is in phase 1 block. Okay, it is in phase 1 block. Succinylcholine at its normal phase 1 block. Okay, let us say I gave my patient 1.5 milligram per kg body weight of succinylcholine, normal dose. Action came within 45 seconds, went within 5 minutes. I repeated 1 milligram per kg body weight of succinylcholine. 5 minutes, action terminated. I repeated 1 milligram per kg body weight. 5 minutes, action terminated. I repeated 1 milligram per kg body weight. 5 minutes, action finished. I repeated 1 milligram per kg body weight again, and prolonged apnea. Now, not in 5 minutes. It is showing a prolonged duration apnea. We say it has entered phase 2 block. Understand? When I give repeated dose of succinylcholine, 1.5, then 1, then 1, then 1, a point comes when the cumulative dose, the added dose crosses 4 to 6 milligram per kg body weight. The succinylcholine starts showing prolonged apnea, and we say it has entered phase 2 block. What happens when we give repeated dose of succinylcholine? The receptor, the nicotinic-cholinergic receptor, gets desensitized by the effect of succinylcholine. Now succinylcholine cannot depolarize it, so it stops behaving like a depolarizing neuromuscular blocker. But the molecule is there, sitting on the receptor but not depolarizing it. So it starts behaving like a non-depolarizing and starts resembling non-depolarizing. That is, train of thought response, positive, TOF ratio less than 1, and post-tetanic facilitation response, positive. Got it? So when succinylcholine enters phase 2 block, starts behaving like a non-depolarizing and starts showing these things. TOF response positive, TOF ratio less than 1, and post-tetanic facilitation response positive. Got my point? Phase 1 block is shown by succinylcholine, phase 2 block is shown by succinylcholine. In phase 1 block is what is normal succinylcholine. Phase 2 block, it starts behaving like a non-depolarizing because the receptor, nicotinic receptor, gets desensitized by the effect of succinylcholine. Right? Management of phase 2 block is also same. Management is same. Ventilation. We ventilate and wait for the nicotinic-cholinergic receptor to get free of succinylcholine. Got it? Guys, very important. Since succinylcholine can enter phase 2 block on repeated dosing, we try to avoid using succinylcholine for maintenance of muscle paralysis. We only try to use it when we don't have to use more than 1 or 2 doses of succinylcholine. Got my point? Okay. Now coming on the side effects of succinylcholine. 14th point. Now, how does succinylcholine act? Attached to the nicotinic receptor, depolarize it. Right? Receptor gets depolarized. Right? No repolarization. Right? And then there is a paralysis. This depolarization is essential for paralysis produced by succinylcholine. What is the mode of action? Persistent depolarization. So we need that depolarization. And all the complications are because of depolarization. Because of depolarization, we'll get a fasciculation. Because of fasciculation, there's a possibility of post-op-myalgia. Because of fasciculation, the closed cavity pressures can be increased by succinylcholine. Right? And because of fasciculation, because of depolarization, some other problems also. So let us discuss the side effects produced by succinylcholine. Side effects. Because of depolarization, fasciculation. Because of fasciculation, post-operative myalgia. Because of fasciculation, closed cavity pressure rises. Intraocular pressure, intracranial pressure, intragastric pressure. These all increases. Got it? 4th point. See on the screen. This is your nerve and this is your muscle. And we have what I talked about, nicotinic receptor on the muscle end plate. We have nicotinic receptor on the muscle end plate. Right, everyone? Okay. This nicotinic receptor present on the muscle end plate are of 2 types. Junctional and extrajunctional, which is not present on junction. When the nerve is stimulated, it will release acetylcholine only in the neuromuscular cleft. So it can only depolarize the junctional receptor. Whenever the receptor is depolarized, it releases potassium. And this potassium participates in muscle contraction. So it is utilized. But when we give IV succinylcholine, it can depolarize both junctional and extrajunctional receptor. And by both, potassium is released. Junctional potassium participate in muscle contraction, utilized. Extrajunctional potassium, it causes hyperkalemia. So whenever we give succinylcholine to any of my patient, I always expose my patient to hyperkalemia, right? And in a subset of patient where this extra junction receptor is proliferated more in number, right, we get exaggerated hyperkalemia. Got it? So we get a hyperkalemia, and the patients in whom this extra junction receptor is proliferated, we get a exaggerated hyperkalemia. We get a hyperkalemia in all patients, and we get a exaggerated hyperkalemia in a subset of patient in whom we avoid using succinylcholine. So what are those patients in which we have a risk of exaggerated hyperkalemia? Number one, muscle dystrophy. Guys, muscle dystrophy, neuromuscular junction is not working properly. The feedback mechanism, the extra junction receptor gets proliferated. Neuromuscular disease. Neuromuscular disease. Okay, neuromuscular disease. Then, third, paraplegia. Fourth, in burn patient, and fifth, in trauma patient. Right? Burn and trauma, acutely there is already hyperkalemia, and let's say chronically in them there is a proliferation of extra junction receptor. So anyways, we don't use succinylcholine. So these are the conditions where we avoid using succinylcholine. You know what I do? I don't use succinylcholine in less than 3-4 year old male child because of the risk of undiagnosed muscle dystrophy. Are you getting my point? Male child more prone to X-linked muscle dystrophy. I try to avoid succinylcholine till 3-4 year old male child because of risk of undiagnosed muscle dystrophy. So these are the conditions in which succinylcholine can cause exaggerated hyperkalemia. Now how do you give succinylcholine? IV. What's the target organ? The target organ is neuromuscular junction, but it would go to other organ also. I told you, whenever drug is in blood, it can go anywhere. If it goes in adequate amount near cardiac muscarinic receptor, what will it do? It is acetylcholine. It will behave like acetylcholine. It will attach and depolarize and cause bradycardia. What does acetylcholine do? Bradycardia. Succinylcholine will also produce bradycardia. Whenever we give second dose or third dose of succinylcholine, in our other hand, we always keep a atropine syringe to manage it. Because on second and third dosing, adequate amount can reach and cause bradycardia. So fifth is bradycardia. And sixth complication, side effect. It can trigger malignant hyperthermia. It can trigger malignant hyperthermia. It can trigger malignant hyperthermia. Guys, this is a rare side effect. This will only be seen when one has malignant hyperthermic gene. But tell me, this 1 to 5 side effect, are they rare side effect? No. They are the side effects which are practically always seen with succinylcholine. And are they innocent side effect? No. They are life-threatening side effect. Which means whenever I give succinylcholine to any of my patient, I expose the patient to life-threatening side effect, which makes it a bad neuromuscular blocker. Not to be used routinely. Our routine neuromuscular blocker, non-depolarizing. Our routine neuromuscular blocker, non-depolarizing. Got it? Okay. Guys, but there are two properties of succinylcholine which force us still to use. So coming on the last point of succinylcholine, uses. Where do we use it? I told you, routinely we don't use it. But there are two properties of succinylcholine which force us still to use it at certain indicated condition. What are those two properties? Fastest onset, shortest duration. Fastest onset, shortest duration. Right, everyone? Now, very important. Where exactly we use succinylcholine? Guys, we don't use succinylcholine for elective intubation, planned surgery intubation, right? Because how do we do planned elective induction intubation? I take the patient inside operation theatre, I attach monitors IV line, and make the patient unconscious. Once the patient becomes unconscious, he becomes high risk of aspiration. But elective on planned surgery, we have done a pre-anesthetic evaluation and kept our patient nil per oral, so the stomach is empty, there is no risk of aspiration. Then I have to maintain anesthesia. For maintenance, I will put the advanced airway. I have to do laryngoscopy and intubation. Guys, how do I do it? I give a non-depolarizing neuromuscular blocker. This non-depolarizing neuromuscular blocker paralyzes, right? But to paralyze, they take some time. They take 3 to 5 minutes. For 3 to 5 minutes, I put a mask on patient's face and do a positive pressure ventilation by bag and mask. Whenever I do bag and mask ventilation, through oral cavity, nasal cavity, air go into two openings, glottic and esophageal. Glottic opening, it is going, chest is rising, that's why we are doing it. Esophageal opening, intra-abdominal pressure would increase. If there is food in stomach, it will come in oral cavity and patient will aspirate. But there is no food in stomach, stomach is empty, so no risk of aspiration. Elective may, we have a luxury of bag and mask ventilation, I can use any neuromuscular blocker. But let's say patient had lots of food, had a party, and met with a roadside accident after the party, right? He is brought to the emergency for some emergency surgery. I'm called for anesthesia. Can I say this? Well, patient had a party just now, a lot of food he has taken. Leave him, we'll take him after 6 to 8 hours till the stomach food go down. Is it possible that I give this excuse and not get the patient operated? No. I have to get the surgery done and I have to see that patient does not even aspirate. For this, we practice a special technique of induction and intubation. We call it rapid sequence induction intubation. So first use of succinylcholine in rapid sequence induction intubation. Okay? Rapid sequence induction intubation. Rapid sequence induction intubation. Guys, very important. This is done for full stomach patient who are high risk of aspiration, or those patients who are always high risk of aspiration, like pregnant female. They have a high intra-abdominal pressure. They are always prone of aspiration. So in them, if I have to give anesthesia, we always practice rapid sequence. Why do we practice? The aim of the technique is to prevent aspiration in these high-risk patients. How do we do it? Coming on the steps of RSI. There are 5 steps of RSI. Let me write it. Let me explain it. Okay? So what are the steps of RSI? Number 1. Pre-oxygenation is mandatory. Pre-oxygenation is mandatory. We pre-oxygenate. We pre-oxygenate our patient, give 100% oxygen. Patient breathe in, breathe out, breathe in, breathe out. 100% oxygen for 3 to 5 minutes. All nitrogen of the alveoli is removed and the alveoli is filled with oxygen. Now if patient goes into apnea and stop breathing, 10-12 minutes there won't be any hypoxia. Normally when we are breathing room air, if we stop breathing, then in 3-4 minutes hypoxia can start. But after pre-oxygenation, for 10-12 minutes, there won't be any hypoxia even if we stop breathing. Okay? So pre-oxygenation is mandatory. Why it's mandatory here? Because we don't have luxury of bag and mask ventilation. After pre-oxygenation, what do? I apply cricoid pressure. See this. The most prominent part of a male's neck, first bony prominent part is thyroid cartilage. The most prominent part of neck of female is this cricoid cartilage. It's a ring-shaped cartilage. This is a ring-shaped cartilage. If I press it, it presses trachea. And trachea is pushed and it is pressing the esophagus. Trachea is covered by cartilage. Its lumen wouldn't collapse. But esophagus is a smooth muscle. Its lumen collapses. Okay, na? So what happens? By applying a pressure, I am trying to collapse the lumen of esophagus. We call it cricoid pressure. Cricoid pressure. or we call it Sellick's maneuver. Sellick's maneuver. Okay. Now third. Then after applying cricoid pressure, I make my patient unconscious. I give IV thiopentone. After giving thiopentone, I give IV succinylcholine. Why I am giving succinylcholine? Why I am using succinylcholine? Why I am not using any other neuromuscular blocker? Because I am in hurry to intubate. I don't want to wait for 4-5 minutes, which I will have to wait for other non-depolarizing neuromuscular blocker. Their action comes in 4 to 5 minutes. With succinylcholine, hardly I will have to wait for 45 seconds. I want a fast action because I don't have luxury of bag and mask ventilation. I want to secure airway as fast as I can. So, succinylcholine. Fourth, positive pressure ventilation by bag and mask contraindicated. Positive pressure ventilation by bag and mask contraindicated. If I do this, what will happen? Patient will aspirate. If I do this, what will happen? Patient will aspirate. Okay? Patient will aspirate. So it's contraindicated. Fifth, we do laryngoscopy plus intubate. So I have done laryngoscopy and intubation. These are the 5 steps of RSI. This is how we do RSI. Right, everyone? This is how we do RSI. Got it, everyone? So guys, RSI, these are the 5 steps. Why I am using succinylcholine? Because I want a fast onset. So these are the five steps of RSI. Got it, everyone? Understood this? So this is the first use of succinylcholine. Second use, very short general anesthesia. When I need very short duration GA, short general anesthesia, as in electroconvulsive therapy, as in endoscopy, right? Very short general anesthesia, right? As in endoscopy, as in, let's say, for very short general anesthesia, we need succinylcholine. As in electroconvulsive therapy, right? As in endoscopy. I don't need GA for more than 5 minutes for these procedure. So I won't use agents which acts for more than 5 minutes, right? We will use succinylcholine, which produces paralysis for 5 minutes. We would use single dose of thiopentone and propofol, which produces unconsciousness for 5 minutes. For very short GA, we used to use shortest acting neuromuscular blocker, and we use succinylcholine, right? And the last use of succinylcholine is, we use it for difficult airway. For intubation in anticipated difficult airway. Whenever we anticipate a difficult airway, we only use succinylcholine. Why? Because we give succinylcholine and try laryngoscopy and intubation. If we fail, at least in 5 minutes, patient will start breathing. We have a backup that it has a shortest duration of action. With other neuromuscular blocker, if I paralyze and I am unable to ventilate and intubate, I may lose my patient by hypoxic arrest. So safe is to use succinylcholine. So these are the 3 uses of succinylcholine. Otherwise we use non-depolarizing. Our regular neuromuscular blocker, non-depolarizing. Got my point? So these are the 3 uses of succinylcholine. Got it? Okay. My closing statement for succinylcholine. AIMS question, what is shelf life of succinylcholine? How do you store succinylcholine? We should store it at 2 to 4 degrees Celsius, and then the shelf life is 2 years, right? We should store it at 2 to 4 degrees Celsius, and then shelf life is 2 years. If I store it at room temperature, the shelf life is 6 months. Shelf life 2 to 4 degrees Celsius, shelf life is 2 years. Room temperature 6 months. So these are the things which we need to know about succinylcholine. Guys, I have discussed this drug extensively. And all the points I have discussed has been extensively asked in the questions as well. But they cannot ask anything more than this. If you know these many points of succinylcholine, all the questions of succinylcholine would be solved easily. And this is minimum we have to know in succinylcholine. Got it? But succinylcholine is not our routine neuromuscular blocker. Our routine neuromuscular blocker is non-depolarizing neuromuscular blocker. Right, everyone? So let us discuss non-depolarizing neuromuscular blocker. Okay? So as I told, our routine neuromuscular blocker is non-depolarizing neuromuscular blocker, not succinylcholine. So let us discuss about non-depolarizing neuromuscular blocker. So our routine neuromuscular blocker, non-depolarizing neuromuscular blocker. What are the points which we know about this? Non-depolarizing neuromuscular blocker are competitive antagonist. They compete with acetylcholine for the alpha subunit of nicotinic cholinergic receptor. Then they do not show fasciculation. They do not show post-op myalgia. And they all are reversed by neostigmine. And they all show trinophore response. They all show trinophore ratio less than 1, and they all show in all of them we can do neuromuscular monitoring, and in all of them post-tetanic facilitation is seen. It is not seen in succinylcholine. So post-tetanic facilitation is seen. Trinophore response is seen. All these points which are repeated for you, revised for you, are the common points shown by all non-depolarizing. Okay? Non-depolarizing neuromuscular blocker divided into two groups. The division is entirely based on difference in their chemical structure, not on the points that we have already discussed. Those are common points. Okay? So non-depolarizing neuromuscular blocker divided into two groups. Right? It is divided into two groups. Amino steroid and benzyl isoquinoline. Okay, amino steroid and benzyl isoquinoline. Right? In amino steroid we have pancuronium, pipecuronium, vecuronium, rocuronium, rapacuronium. Okay, pancuronium, pipecuronium, vecuronium, rocuronium and rapacuronium. Now benzyl isoquinoline, D-tubocurare, doxacurium, itracurium, cisatracurium, mevacurium. Right? So these are the 10 drugs that we have to discuss. Okay? So these are the 10 drugs which I will discuss with you. First two drug of both the group, long acting. Second two drug of both the two group, intermediate acting. And last one is short acting. This is according to the duration of action. Okay? So, few common points of both the group I want to tell you. And then individual drugs I would discuss in the chart itself. This would be the chart for non-depolarizing. Okay. So what are the few common points which I need to tell you? I want to tell you that benzyl isoquinoline, this group, because of its chemical structure, is notorious in releasing histamine. They are histamine releaser. Right? So histamine releaser. Right? Notorious in releasing histamine releaser. Okay. If a drug releases histamine, what would be the clinical features when we give that drug? Histamine causes vasodilatation. So hypotension. Because of hypotension, tachycardia. And because of histamine release, it can cause bronchospasm and it can also cause flushing in the patient. So typical 4 features, clinical features of histamine release: hypotension, tachycardia, then flushing and bronchospasm. Okay. This group, aminosteroid group, no histamine release. No histamine release. No histamine release. And these bad clinical features, hypotension, tachycardia, flushing, bronchospasm, it will not be seen with aminosteroid group, right? So please tell me, which group should be cardiovascular stable? Definitely aminosteroid. No histamine release, no hypotension, no tachycardia. So this group is cardiovascular stable. This group is cardiovascular unstable. Okay. So these are the common points of both the group. Now see the drugs. Guys, before I go on individual drugs, I want to summarize few things for you. Neuromuscular blocker divided into 2 groups: depolarizing, non-depolarizing. Depolarizing neuromuscular blocker, succinylcholine, accompanied with life-threatening side effect. Right? Non-depolarizing neuromuscular blocker is what we are using routinely. Succinylcholine is accompanied with life-threatening side effect. We don't use it routinely. Our routine neuromuscular blocker, non-depolarizing. Again divided into 2 groups: aminosteroid, benzyl. Benzyl, cardiovascular unstable, benzyl isoquinoline. Aminosteroid, cardiovascular stable. And aminosteroid, they are cardiovascular stable and is what we are using routinely. And today in our OT, we preferably use the intermediate acting neuromuscular blocker, not long acting. So for every patient requiring general anesthesia, right, requiring paralysis under general anesthesia, we use either vecuronium or rocuronium. These are the commonest used neuromuscular blocker because they have the best clinical profile, right? Understood? Now let us go on individual drugs. Whatever common points in the chart is mentioned, I wouldn't write it separately. Whatever extra point we have to write, we would write it separately. Okay? Let us start with the first drug, pancuronium. What are the points of pancuronium clear from the chart? Aminosteroid, long acting, no histamine release, would not show this bad clinical feature, should be cardiovascular stable, right? But here pancuronium differs. All aminosteroid, first extra point, all aminosteroid except pancuronium. All aminosteroid except pancuronium, cardiovascular stable. What is the problem with pancuronium? Pancuronium causes vagal blockade. Vagal blockade. And since it causes vagal blockade, parasympathetic block, it is associated with hypertension and tachycardia. Right? It is associated with hypertension and tachycardia. Right? Which makes this drug cardiovascular unstable. I have never seen a question on pancuronium apart from this point, that though it belongs to cardiovascular stable group, it is cardiovascular unstable. Got my point? Okay. Next comes pipicuronium. What are the points clear from the chart? Aminosteroid, long acting, no histamine release, would not show those bad clinical feature, cardiovascular stable. Nothing else. Never seen a separate question on pipicuronium. Never seen a separate question on pipicuronium. And we don't need to discuss anything apart from this on pipicuronium. Then comes vecuronium. Intermediate acting, aminosteroid, no histamine release, would not show those bad clinical feature, cardiovascular stable. Right? No extra points. Then comes rocuronium. Before I tell you anything extra about rocuronium, I just want to tell you, discuss few things. Fastest acting neuromuscular blocker. Fastest neuromuscular blocker. Fastest onset, of course. succinylcholine. Succinylcholine. Onset 30 to 45 seconds. ठीक है. Fastest non-depolarizing neuromuscular blocker. Fastest non-depolarizing neuromuscular blocker, rapacuronium. Rapacuronium. Onset 75 seconds. But rapacuronium is clinically not available. Second fastest non-depolarizing. Second fastest non-depolarizing neuromuscular blocker, rocuronium. Onset 90 seconds. Rest all. Apart from this, rest all. Rest all. Late onset. Late onset. 3 to 5 minutes. So, succinyl fastest overall. Among non-depolarizing, rapa fastest, but it is not available clinically, rapacuronium. Second fastest, rocuronium. It is clinically available. So, fastest clinically available non-depolarizing, rocuronium. Why do we use succinylcholine for RSI? Fast onset. If for any reason I can't use succinylcholine for RSI, patient already has a hyperkalemia or something like that, then instead of succinylcholine, I would use rocuronium. So they ask, which non-depolarizing neuromuscular blocker can replace succinylcholine for RSI? Answer is rocuronium. Got my point? So extra points of rocuronium. Rocuronium. Fastest clinically available non-depolarizing neuromuscular blocker. Fastest clinically available non-depolarizing neuromuscular blocker. Onset 90 seconds. Onset is 90 seconds. Got my point, everyone? Okay. Very important. Can replace succinylcholine for RSI. Can replace succinylcholine for RSI. Got it? Okay. Now very important next point. Guys, IV injection of rocuronium can cause pain. This has been asked in All India Entrance Exam. So just keep it in mind for repeat questions. So 3 drugs till now we have discussed which causes pain on IV injection. One is propofol, etomidate and rocuronium. Okay? So IV injection causes pain. IV injection causes pain. Got it? Okay. Now please see on the screen. Rapacuronium. Short acting aminosteroid, no histamine release, would not show these bad Kinker feature and cardiovascular stable. Extra point, fastest non-depolarizing. If in fastest non-depolarizing, rapa is in the option, we have to go for rapa as an answer. Rapa not an option, rocuronium. Got it? So rapa. Got my point? Rapa is not available clinically. It has been removed from clinical use because a problem of bronchospasm was seen with it. It doesn't release histamine. Itself causes bronchospasm by some mechanism. It was totally removed from clinical practice, not asked in exam. Only one possible question of rapacuronium, fastest non-depolarizing. Got it? So this finishes our aminosteroid group. One more thing about aminosteroid group. All neuromuscular blocker belong to this group. Are metabolized by liver and kidney, hepatic and renal metabolism. Okay? So all neuromuscular blocker belong to this group are metabolized by liver and kidney. Now coming on, benzyl group. First drug of benzyl group, D-tube curare. Long-acting benzyl isoquinoline. Potent histamine releaser will show those bad Kinker feature, cardiovascular, unstable. So guys, what do we need to know about this D-tube curare? D-tube curare. This drug has historical importance. This drug has historical importance. ठीक है? you know, those tribal people, they use bow and arrows to kill their victim, and their arrows are coated with the curare plant extract, which they send in the victim's blood and cause respiratory muscle paralysis. This was noticed by Dr. Harold Griffith. And what did he do? He separated the curare plant extract and made D-tuberculare. And first neuromuscular blocker was used clinically. So D-tuberculare is first neuromuscular blocker. It is natural neuromuscular blocker. It is a natural neuromuscular blocker. Right, everyone? First neuromuscular blocker, natural neuromuscular blocker. The only problem of D-tuberculare was intense histamine release. In histamine release, maximum histamine release, D-tuberculare. Then atracurium equal to mevacurium. Then atracurium equal to mevacurium, and then your doxacurium. So guys, D-tuberculare, massive histamine release. That was a major problem. So what Dr. Griffith did, he separated a metabolite of D-tuberculare and made doxacurium. This D-tuberculare metabolite is doxacurium, exactly similar to D-tuberculare except that less histamine release. Right? Now, both D-tuberculare, doxacurium, not much in clinical use. Now comes the next neuromuscular blocker, very important neuromuscular blocker. From exam point of view, atracurium. Now, what are the points of atracurium which we know? Atracurium, which we know. We already know few points of atracurium, right? We know that it is intermediate duration acting, benzyl isoquinoline, right? Intermediate acting benzyl isoquinoline, ठीक है? Histamine releaser causes hypotension, bronchospasm, tachycardia, and flushing. Is cardiovascular unstable. All the 5 points written on the screen we have already discussed, right? We have already discussed all the 5 points written on the screen, right? Now the 6th point, the additional point. 6th point. Guys, metabolism of ATRA is unique. Now I told you all aminosteroid is metabolized by liver and kidney. Atracurium has a unique metabolism in the name of Hoffman degradation. Hoffman degradation. What is this Hoffman degradation? Hoffman degradation is non-enzymatic, time-bound self-destruction of drug. Right? What is it? Non-enzymatic, time-bound self-destruction of drug. ठीक है? Non-enzymatic, time-bound self-destruction of drug. This is our Hoffman degradation. Okay, everyone? Right? Non-enzymatic, time-bound self-destruction of drug. We also call it non-organ elimination. Every half an hour, some internal rearrangement happens in ATRA molecule and it is metabolized. That's called Hoffman degradation or non-organ elimination. Since it metabolized by Hoffman degradation, it doesn't need liver and kidney for its metabolism. It becomes muscle relaxant of choice in number 1, acute chronic liver disease, acute chronic kidney disease, pregnancy, pediatric, old age. Okay. All these conditions, liver function, kidney function may be deranged. Muscle relaxant of choice becomes atracurium. Okay. Guys, atracurium is metabolized by Hoffman degradation, right? And by Hoffman degradation, it produces a byproduct, right? It produces a byproduct, and this byproduct is something called laudanocin. What is this laudanocin? Laudanocin is a byproduct of atracurium metabolism, and this laudanocin can cause epilepsy. Its accumulation, laudanocin accumulation, can cause epilepsy, right? So this can cause epilepsy. Understood? So what is good about atra? We talked about the points of atra. What's good about atra? Let us paint the good point of atra with yellow. It is muscle relaxant of choice in all these conditions because it's metabolized by Hoffman degradation. Let us mark all the bad point of atra by red. Histamine releaser, bad clinical feature, cardiovascular unstable, and laudanocin production. Now guys, yellow points retained, red points decreased or minimized. A new drug, cisatracurium. Atracurium is mixture of 10 isomer, right? Atracurium is mixture of 10 isomer, right? It's cis isomer. It is mixture of cis, cis, trans, 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 cis, etc., etc. Its cis isomer was separated, and a pure cis atracurium molecule was made, which, like atra, is intermediate acting. Like atra, benzyl isoquinoline. Unlike atra, it is not metabolized by. Unlike atra, it does not cause histamine release. Would not show these bad clinical feature. Is not cardiovascular unstable. So we saw the red points removed. Okay. Like atra, metabolized by Hoffman degradation. Like atra, muscle relaxant of choice in all these following conditions, right? And like atra, metabolized by Hoffman degradation, so it will produce laudanocin, but being more potent than atra, less dose is given. Guys, cis atra is 5 times more potent, right? 5 times more potent than atracurium. Cis atracurium is 5 times more potent than atracurium. So less dose is given. Less dose, so less byproduct. Less byproduct, less laudanocin, less epileptogenic. So this is what is the benefit of cis atra over atra. Any question? ARF, CRF, ALD, CLD, pregnancy, pediatric, old age, neuromuscular blocker of choice. If atra is in the option, atra answer. If cis atra is in the option, cis atra option. Answer. Both in the option, then answer would become cis atra. Better atracurium. Cis atra is a better atracurium. Next question asks, laudanocin is metabolite of which neuromuscular blocker? Answer is atra. Atracurium. Not an option, cis atracurium. PGI question, both atra and cis atracurium. Got my point? Okay. Now very important. What are the benefits of cis atracurium over atracurium? So let us write the difference in a tabular form of atra and cis atracurium. Okay? So difference between atracurium and cis atracurium. Okay, what is atracurium? It is mixture of 10 isomer, cis, 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 trans, etc., etc. What is cis atracurium? Pure cis isomer. Second, atracurium, histamine release. Histamine release. Cis atra, no or very minimal. Minimal histamine. Minimal histamine. Okay. Then third point. Atracurium, cardiovascular, unstable. Cis atra, cardiovascular, stable. Okay. Then fourth. Dose of atra. Dose. 0.5 to 0.6 milligram per kg body weight. Per kg body weight. Cisetra dose 0.1 to 0.15 milligram per kg body weight. So guys, 5 times more potent than Atra. Fifth point, less dose, less byproduct. Less byproduct. Less dose, less byproduct. Got it? So definitely Cisetra is less epileptogenic than atracurium. So this is the difference between Atra and Cisetra. Okay? Now coming on the last non-depolarizing neuromuscular blocker, mivacurium. So what do we know about mivacurium? Common points from the chart. Short acting benzyl isoquinoline. Benzyl isoquinoline. Right? Then histamine releaser. Then cardiovascular unstable. These points clear from the table itself. I've just repeated it here. Guys, what do you else know about MIVA? Do we know the onset of action of MIVA? Have we discussed? Yes, we have discussed. I told you, succinyl 45, Rapa 75 seconds onset, rocuronium 90, rest all 3 to 5 minutes. So MIVA onset, late onset, it has a late onset, 3 to 5 minutes. But duration, shortest among non-depolarizing. Duration, shortest among non-depolarizing. ठीक है? Duration shortest among non-depolarizing. ठीक है? Got my point, everyone? So it has the shortest duration of action. MIVA is metabolized by pseudocolinesterase. Metabolism, pseudocolinesterase. MIVA is metabolized by pseudocolinesterase, right? And MIVA metabolized by pseudocolinesterase, the same enzyme which metabolizes succinylcholine. So we got 2 drugs metabolized by pseudocolinesterase, succinylcholine and mivacurium. We will get few more drugs which we will note down in the end because they ask drugs metabolized by pseudocolinesterase. Got it? So this is all about mivacurium and all about non-depolarizing neuromuscular blocker. Before finishing off this topic, I want to tell you 2 more things in non-depolarizing neuromuscular blocker rather. I want to discuss clinical conditions and drugs which potentiates the action of neuromuscular blocker. I want to give the list. Guys, in newer neuromuscular blocker, I want to discuss one very important drug which is being asked nowadays in few of the exam. That's gantencurium. So, new neuromuscular blocker. Neuromuscular blocker. Guys, this is a non-depolarizing neuromuscular blocker. This is non-depolarizing. So what we have studied in non-depolarizing neuromuscular blocker, it has 2 groups, aminosteroid and benzyl isoquinoline. This non-depolarizing neuromuscular blocker, the new one, is gantencurium. This gantencurium does not belong to any of the group benzyl isoquinoline or aminosteroid. It is a new group. It is a new class of neuromuscular blocking, a asymmetric mixed onion chlorofumarate. So chemically, it is asymmetric mixed onion chlorofumarate. Right? It's chemically asymmetric mixed onion chlorofumarate. It's a single isomer. Right? Like your cis-atracurium. Otherwise, your atracurium, mivacurium, they are mixed isomer. This is gantencurium is a single isomer, only one isomer, right? Now this is ultra short acting, the important properties of this drug. This is ultra short acting, rapid onset. It has rapid onset. So both are the benefit. Rapid onset. So ultra short acting, rapid onset. Both make it similar. In pharmacokinetic to succinylcholine. Succinyl we have discussed. Fastest onset, shortest duration. Gantacurium also has ultra short acting, and it also has ultra short acting with a short duration and rapid onset, right? So pharmacokinetic is similar to succinylcholine, right? Now benefit of this drug is its metabolism also. Another benefit is metabolism. It metabolism by two pathway. Number one, chemical degradation, right? It does not undergo enzymatic degradation, so does not need the liver and kidney for its metabolism. Chemical degradation by L-cysteine, right? And second, pH sensitive hydrolysis. So in metabolism, no renal or hepatic involvement. So no renal and hepatic involvement. So guys, seeing succinylcholine's side effect, is Gantacurium the answer for requirement of ultra short action and rapid onset? Yes. Once it is introduced, then it will totally replace succinylcholine. Its metabolism is independent of renal and kidney and hepatic, undergoes self-metabolism like A-transacetyl, is rapid onset, shortest duration like succinylcholine. So it is combining the benefit of so many other drugs. So I told you it's a new neuromuscular blocker, a new non-depolarizing neuromuscular blocker. Chemically, it is asymmetric mixed onion chlorofumarate. Chemically, it's a single isomer, and it has a very favorable pharmacokinetic property similar to succinylcholine, ultra short acting, and it has a rapid onset. Metabolism is unique, chemical degradation by L-cysteine, and pH sensitive hydrolysis. No renal and hepatic involvement, right? So this is the benefit. New non-depolarizing neuromuscular blocker. Now there is one more drug, just name I want you people to keep in mind, still not introduced in clinical practice, a new reversal agent. Right. This in reversal agent, what we are using today is neostigmine and your Sugammadex. Neostigmine is an indirect reversal agent, acts simply by increasing the quantity of acetylcholine. Sugammadex, it combines with aminosteroid group of non-depolarizing neuromuscular blocker, and it is reversal agent only for the aminosteroid group of non-depolarizing neuromuscular blocker, especially becuronium and rocuronium. There is a new reversal agent, calabedion. This calabedion is a specific reversal agent which can capture any of the non-depolarizing neuromuscular blocker. So this is specific reversal agent which can capture both aminosteroid and benzyl isoquinoline non-depolarizing neuromuscular blocker. Both aminosteroid and benzyl isoquinoline non-depolarizing neuromuscular blocker. This is calabedion. So this is all in two new drugs which I wanted to talk in neuromuscular blocker. A new reversal agent in the name of calabedion, and a new drug, a new neuromuscular blocker in the name of Gantacurium. Okay. And I want to discuss about something called reversal agent. We talked about reversal of general anesthesia. I told you, we have luxury of having reversal agent against some drugs. One of them is neuromuscular blocker. So we'll talk about the reversal agents. Okay. So let us discuss. First, the drugs and clinical condition potentiating neuromuscular blocker. Drugs and clinical conditions potentiating neuromuscular blocker. Right? Drugs and clinical condition potentiating neuromuscular blocker. Right? What are the drugs and clinical conditions potentiating neuromuscular blocker? Okay. Guys, first some antibiotics. Some antibiotics. ATP. A for aminoglycoside. A for aminoglycosides. Glycosides. T for tetracycline. P for polypeptide. Right? These three antibiotic potentiate. Then, second, some antiarrhythmics. Antiarrhythmics. Quinidine, calcium channel blocker. Calcium channel blockers. Quinidine and calcium channel blockers. Okay. Then magnesium, hypermagnesemia, potentiate neuromuscular blocker. Then acidosis, potentiate neuromuscular blocker. Then hypothermia, potentiate neuromuscular blocker. Okay. Then guys, potent inhalational anesthetic agents, our SIBO, DES, they potentiate neuromuscular blocker. Potent inhalational anesthetic agents. Potent inhalational anesthetic agents, right? Our desflurane, sevoflurane, isoflurane, halothane. So desflurane, sevoflurane, isoflurane, halothane, they all potentiate neuromuscular blocker. Got it? Seventh, some neuromuscular diseases. Neuromuscular diseases. Guys, in this I want to talk about myasthenia gravis. What happens in myasthenia gravis? I want to particularly talk about myasthenia gravis. They ask question on myasthenia gravis. So what happens in myasthenia gravis? What happens in myasthenia gravis? There is autoantibody against the neuromuscular receptor, that is nicotinic cholinergic receptor. There is autoantibody against nicotinic cholinergic receptor. And what happens? Because of this autoantibodies, this receptors gets destroyed, right? So what happens? Acetylcholine doesn't get a sufficient amount of receptor and we get, let's say, weakness, muscle weakness. Remember, where acetylcholine cannot act, succinylcholine cannot act. So these patients are resistant to succinylcholine, depolarizing neuromuscular blocker. And they are more susceptible to non-depolarizing neuromuscular blocker, right? So myasthenic patient, they are resistant to succinylcholine and more susceptible to non-depolarizing. Okay, more susceptible to non-depolarizing. Got it? So this is the clinical conditions and drugs potentiating neuromuscular blocker. Got my point? This is being asked lately, guys. Previously it was very much asked, but in middle, like last 5 years, 6 years back, they stopped asking question on this point. But I have seen lately in few exams last year that they have asked question on drugs and clinical condition potentiating neuromuscular blocker. So keep this in mind. Okay, this is important. Now coming on the last point of neuromuscular blocker, reversal agent. Reversal agent. let us talk about reversal agents. Guys, just few things you have to write it. First, understand properly. This is your nerve, this is your muscle. Now, let us say I have given my patient IV vecuronium. What is vecuronium? Vecuronium is non-depolarizing aminosteroid intermediate acting neuromuscular blocker. That's a description. So what I did, I gave vecuronium. So vecuronium is sitting on the nicotinic receptor, occupying it, and muscle paralysis has come because acetylcholine cannot come in contact with these receptors. Vecuronium is intermediate acting, right? So after 45 minutes, vecuronium starts dissociating. The receptor becomes empty. Acetylcholine gets a chance and starts occupying the receptor, and the muscle power of the patient starts returning. At this point of time, we clinically see that muscle power has returned. What do we do? We give neostigmine. If I want to reverse, of course, then if I give IV neostigmine. What does neostigmine do? Neostigmine stops the action of acetylcholinesterase and recruits the quantity of acetylcholine in huge number of acetylcholine at neuromuscular junction. Outnumbers vecuronium immensely, and the reversal is good. Even if I don't give neostigmine, I would get a reversal, right? Just to help for a good reversal, I'm giving neostigmine, right? And neostigmine which I'm using for reversal, I cannot give it alone because it will increase the quantity of acetylcholine near neuromuscular junction. It will also increase the quantity of acetylcholine near cardiac muscarinic receptor. So it will be accompanied with muscarinic side effects like bradycardia. So we give neostigmine mixed with atropine or glycopyrrolate. Why is this atropine or glycopyrrolate added? This is added to counteract the muscarinic side effect of neostigmine. Counteract muscarinic side effect of neostigmine, right? This is to counteract the muscarinic side effect of neostigmine. Got it? Okay. So what kind of reversal agent is neostigmine? Does it have a direct effect on neuromuscular blocker? No. It is acting indirectly simply by increasing the quantity of acetylcholine. Got it? There is a new drug in the market that's called Sugamadex. There is a new drug in the market called Sugamadex. Not very new. It's there from last 2 to 3 years. We are using it at some centers. What is this Sugamadex? It is a cyclodextrin compound. The structure of cyclodextrin is similar to the structure of aminosteroid, right? So how does this Sugamadex act? Let us again build up the same situation. I gave IV vecuronium, and vecuronium is sitting on the nicotinic receptor, and within 10 minutes surgery finished, I have to reverse my patient. Inhalational IV, I will simply stop. How to reverse the neuromuscular blocker? Neostigmine can only act as a reversal agent at a stipulated time when the vecuronium will dissociate. So I will have to wait for another 30 minutes. Well, no, if I have Sugamadex. I will give Sugamadex to my patient. Sugamadex will go and it will bind with vecuronium. Cyclodextrin structure similar to the aminosteroid. And Sugamadex will engulf vecuronium, eat the vecuronium up, and take the vecuronium away from neuromuscular junction. 3 important points you have to know about Sugamadex. Asked in exam: direct reversal agent, acts only against aminosteroid group, and acts best against vecuronium and rocuronium. Got it? So let us write it. It's a direct reversal agent. Directly bind to the neuromuscular blocker. So direct reversal agent, then acts only against aminosteroid and best against, it acts best against vecuronium and rocuronium. Okay? It acts best against vecuronium and rocuronium. This is all we need to know about Sugamadex, and this is all we need to know about neuromuscular blocker. So we have finished the pharma part of general anesthesia. We have finished inhalational anesthetic agent, we have finished IV anesthetic agent, and we have finished neuromuscular blocker. Got it? So we have finished pharma part of general anesthesia extensively. They form a bulk question, right? Now on we will take the topics clinical aspect of general anesthesia. Okay.